All right, so welcome tonight to our conversation about single payer, a reflection on the past, present, and future. Really appreciate everybody joining and to our speakers especially. So I want to start this with a land acknowledgement. So today, the majority of us are joining from Chicago or Chicago, and let us always remember that we are on Indigenous land. The region we now refer to as Chicago, along with the larger region, has always been home to Indigenous peoples, including the Council of the Three Fires, the Potawatomi, the Odawa, and the Ojibwe, and the Illinois Confederacy, Peoria, the Kasekaki Nations, the Miami, the Weye, the Ho-Chunk, the Menominee, the Thakiwaki, the Mesawaki, Kickapoo, and the Mascoutin, along with many other Indigenous nations. Chicago is also home to one of the largest urban Indigenous communities in the United States. This land remains an important place for Indigenous peoples. The institutions we work in and for are settler colonial structures on land stolen through genocide against Indigenous communities. These structures we have continually exploit Black and Indigenous people, and we must be cognizant of that when we have conversations about racial justice. These conversations are intrinsically linked to the conversations for Indigenous sovereignty and self-determination, conversations about transnational solidarity. It's our responsibility to acknowledge this historical context and build reciprocal relationships with the tribal nation on whose land we are situated. So for folks that are here, do what you got to do to be here and to make yourself comfortable. You're welcome to have your cameras on or off. We are not planning on having closed captioning during this session. If that is going to impede somebody's access to this session, please send me a direct message right now and we can leave slides up and put closed captionings on. We just don't have an automatic system built into Zoom, and we're just planning on having a regular conversation on Zoom during this session. If something isn't being met or there's an issue, feel free to message me or to message Rex. My phone number is on the next slide here. You can also, or on the one after this, you can send us a text. So just a little bit about the Chicago Health Coalition for Black Lives. We're a group that came together in June to support the uprising after the murder of George Floyd and Breonna Taylor and others. And our political education team has been working since this time to have different political education sessions and seminars to discuss the intersection of race, health, and liberatory politics. Our guests tonight, we're very pleased to have are Dr. Susan Rogers and Dr. Peter Gann. So Dr. Rogers is president for Physicians for a National Health Program and recently retired from Cook County, and I believe is still working at Rush and volunteering at Cook County. Dr. Rogers, please correct me if I'm wrong. But she got her degree from UIC Chicago and completed residency at Cook County and has been involved in many different fights for health justice over the course of her career. Dr. Gann has been a member of PNHP for over 20 years and is a member of the steering committee for the Illinois chapter of PNHP. He's currently a professor at UIC College of Medicine, where he teaches and conducts research on cancer prevention and public health. During his career, he's worked as a primary care physician in occupational environmental health and at the state health department. We are very grateful to have you both join us tonight, so thank you. For folks that are here, feel free to introduce yourself in the chat and let us know why you're here, what your questions are, what you want to hear about. And also as we go through the sessions, if there's anything that you're curious about or you want to ask, I think there's about 15 of us here. It's not too many folks, so you can drop a session in the chat or even unmute and ask a question if you got something that's really burning. So, take care of yourself, show up as you are. Let's have a great conversation and learn. And if you have any issues or any concerns at all, and you don't feel like reaching out through the chat, you can also send me a text message at the number listed on the screen there. And so without further ado, I'm going to stop sharing my screen, turn it over to Rex, and we can get this conversation started.
Well, hello, everyone. So in case if you were wondering, I am Rex. I'm a fourth-year medical student at the University of Illinois at Chicago, and I'm involved in Students for a National Health Program, which is the student arm of PNHP, where both Dr. Rogers and Dr. Gann hail from. And I would love for us to get started by just exploring a little bit of the historical context of how we got here. How did we end up with this kind of system of healthcare delivery and industry in the US? So can we briefly discuss how the US ended up with the healthcare system it currently has, and how this historical context shaped the founding of PNHP and the current single payer movement?
Okay, thank you both for the introduction, and I'm happy to be here and join you all tonight and looking forward to the conversation. So I am going to go back and kind of give some highlights of historically what has happened that has created the system that we have. And like you said, Rex, what prompted the formation of PNHP and, where we are now. But if we look back at the beginning of around the 1900s, really, I don't even know what healthcare was then, because there weren't that many medications. When people got sick, especially with infectious diseases, most of them, they died because there was no way to treat them. And at the time, when people got ill, it was really the loss of wages that impacted them financially, not the cost of healthcare, because most healthcare was just potions and hand-holding and whatever along the way. The hospitals that were there at that time were just charity hospitals or poorhouses where people actually just went to die, not really for healthcare. Now, the AMA was actually established back in 1847. And even at that time, they looked at healthcare as a private business transaction between the doctor and the patient. So even from the beginning, what the AMA's role seemed to be was protecting and perpetuating the economic aspect of healthcare for physicians. Now, also around this time, there was a man named Flexner who started looking at medical education and hospitals and all of that. And he was funded by the AMA and Carnegie. And he actually revolutionized medical education based on them. And what he did is it took him over 15, 20 years, but he's the one that came up with the idea of 2 years of basic sciences, 2 years of clinical work, and it started at Johns Hopkins. And this is what our medical education is now. There are variations of that, but that's really the architecture of medical school education now. So one of the bad parts of this, though, was that there were, when he started, there were 10 Black medical schools at that time, and he eliminated all but 2 of them. And that's because Black schools at the time were only funded by the fees and the tuition that their students were able to pay. They were not funded by the government like white schools. There were not wealthy Black people to be philanthropic donors to the Black medical schools. So even from the very beginning of medical school education, there was an inequity that was sustained and promoted, and the inequality of the education and the access to the education was built into the system from the very beginning. Now, when we got to about the 1920s, there were countries in Europe that were already starting some national health insurance programs, but there was no support for that here in this country. And it was opposed by doctors and pharmacists. And again, it was about, they felt that they would lose money, that it meant that they would get lower fees. So in the very beginning, this was all about the money. And at the time, there was no health insurance yet. They made their money off of burial insurance. So like I mentioned before, healthcare was really non-existent, and the financial impact was the loss of wages. Now, later on, there was a labor group at Baylor Hospital in Texas that actually started what they called a prepaid hospital care for teachers. And what it was they paid an amount, it was about 50 cents a month, which is an equivalent about $5 in today's money. And this would provide them care if they got sick. And this is what actually was the beginning of Blue Cross. And it's interesting how they developed this, because they realized that women were spending more on lipstick and cosmetics than the 50 cents for this health care. So it was actually an easy sell at that time. But over time, science was evolving, even in the medical schools, it was more science-based versus an apprentice type of learning. The population was becoming more urban, so that it created a need for more hospital care. And with Flexner's influence on hospitals, they went from being charity care to really hospitals associated with medical schools and prestigious institutions related to education. And with that, costs increased. Doctors and nurses too became more professional, and the education of these professionals became more consistent and nationwide. It was more equalized. Licensing got started, so that it became a more professional scientific endeavor than it used to be. And even in Europe, as I mentioned before, they were starting their national health insurance, but here it never took off. A lot of that was because there were a lot of unemployment issues rated from that stemmed from the Depression, the Great Depression. There was the Dust Bowl in the mid 1930s that just devastated the farming economy, and people left the Midwest. And so it took the focus off of private health insurance here. Now, in World War II, that was when private health insurance actually started getting linked to employment, because at the time during the war, there was rationing. The government said you couldn't increase salaries, you couldn't do any of that because they were worried about post-war inflation. So what they did was they said you could give benefits. And so the benefit they chose to give to people in this country was health insurance. And so this is where private health insurance really took off. Now, during this time, insurance companies thought this was ideal. Number one, there was no adverse selection, in the sense that people who worked are generally healthy. They're healthy enough to go to work every day. They aren't that old. They aren't retired. This is the group that you want to insure. So you have a low risk pool. Now, when Truman came into power, he tried to support a national health insurance plan and attach it to Social Security. But even this plan was it could never have been created to apply to everyone. Everyone couldn't have gotten health care through this way. If we look at Social Security, when Social Security was passed in the New Deal with FDR, it left out farmers and it left out domestics. And who were the majority of those people? Those were Black people who lived here. So that tying, health insurance to Social Security and all was still disenfranchising people of color here. So again, this inequity was being, sustained, promoted, and becoming more cemented into the structure that we have here. And so actually, private health insurance during this time after the war and into the early 1950s, it just exploded. At the beginning of 1940, we hadn't even gotten into the war yet, but only about 9% of the country had private health insurance. By 1953, 63% of the country had private health insurance through their employer. And this decreased the support for national health insurance for a couple reasons. One, the jobs people had in those days, they had forever. Nobody was worried about, I'm going to lose my job and lose my insurance, because you stayed at the same job for 40 years. And so the tying together was not looked at as a fragile thing the way we see it now. because it would last. And so for years, there was little worry about losing your insurance. Now, in 1952, that was when Medicare was first proposed, although it wasn't enacted until almost 15 years later. But the idea of Medicare was gaining traction, for one, because it helped increase physicians' salaries. And again, this is still the salary motive that the AMA was promoting and backing. And at this point, the AMA represented almost all the white doctors in this country. Blacks were not able to be members of the AMA. So it was really representing the interests of white doctors in this country. Now in 1953, and one of the things I forgot to mention was that when private health insurance started during the war, the way they were able to get around this was that the employer did not pay taxes on the dollars that went towards the benefit of providing health care. And so it was not salaries, so that it was a win for both. The employer didn't have to pay taxes on it, and the employee didn't have to pay taxes on that money that they got for their health benefit. So around the early 50s, though, the IRS was saying, this is a lot of money going into these benefits that the IRS isn't getting any benefit from. And so they wanted to start taxing these benefits. And this is when Eisenhower was elected, and he started all of the anti-socialism. This is socialism, national health insurance is. It's socialist, and we can't have that. We have to stick with our private health insurance. And he convinced Congress to not allow the IRS to tax these benefits. And this is what cemented this for this country. This is what made employer provided health insurance a win-win for everyone, so everybody thought. The employee got the benefit of the insurance without having to pay tax. The employer didn't have to pay tax on providing that benefit. And so it helps cement that. Now, keep in mind too, that also during this time, Black people weren't being employed the same way that whites were. All the benefits of the GI Bill, Black GIs didn't get benefit of. They couldn't get into the training. They couldn't get use of the GI Bill for tuition in college. And also the mortgages from FDR, they couldn't avail themselves. So they weren't able to buy a home and accrue equity in the home and generate wealth, which is how most of it did. And so all of these policies, what they did was they created the white middle class. And it was this white middle class that was working, that had the benefit of private health insurance at no expense to them, very little at that point. And like I say, these inequities were created purposely. They were built into the structure of how these things were developed. So all of this created all of these problems. Now, later on, when JFK became president, he became obsessed with Medicare because his father had a stroke, and the story is told that it made him realize that if his father wasn't so wealthy and able to pay for his own health care, who knows what would have happened. And that's what kind of prompted him to promote Medicare for all. And so we have just continued down this road ever since the IRS was not able to tax these benefits. They become part of the makeup of this country, part of the culture of this country. And here we are today, and it is just blown out of proportion. The costs are increased. So now it's not a win-win anymore. Employees don't see it as a win-win in the sense that they have this insurance through their employer, but they're not often able to access it because they can't pay the deductible. The deductibles have risen, the out-of-pocket expenses, we all know this, so that it's not the savior that everybody thought it would be. And just as how in the 30s and 40s, when antibiotics came about and saved lives and became wonder drugs, we now have another group of wonder drugs that are just horrendously expensive. And we can't take advantage of that. So even though medicine has developed and grown. So one of the things that prompted PNHP to be developed was that they saw that these, the things that were being done politically were really not doing anything to provide care for all. And that's what prompted their decision to create this organization in the early 80s, Physicians for National Health Program. And they saw that the safety net hospitals were being, all the safety net programs were being destroyed, and that there had to be something done to provide health care, knowing that this wasn't going to solve all of the problems that were there. And so, I had a list of the things that they had said that the reason they were doing it, and I wanted to read it off that list, but I don't see it in front of me. But a lot of this is on the PNHP website, but that's what prompted that organization. And it was a group of very progressive, very left-wing folks, some of whom are still very active. The founders, Dr. Himmelstein and Dr. Wohlhandler, are still active in the organization. Dr. Fagan, who was very active in the beginning with Quentin Young when they moved the offices to Chicago from New Hampshire. And so it's kept this very left-wing, very focused, because it did not want to be diluted, even though no one was naive thinking that if we can provide access to care and build hospitals in poor neighborhoods, that will make everyone who lives there healthy. It's not that naive, but it's focused on healthcare so we don't dilute the message. And one of the things I think about being an activist that is so different from being a politician is that an activist, you don't feel you have to compromise. You know what you want, and that's what you're going for. And that's the difficulty with, I think, dealing with politicians, is their whole life is built around compromising. And so it's a relationship that's difficult, because your mechanism of getting what you want are kind of different. But that's why PNHP was developed, and that's why it has still grown. Initially, its whole role was to provide information, to educate doctors, to educate the population, to show by data that this is what will work, not because I think so, but the data that proves that it will work. And that's where we are today.
Great. Yeah, thank you for that context and that wonderful arc that you took us through there up to today. And I'm wondering if you could, sort of building on that, you had mentioned that one of the goals of PNHP was sort of using that data, evidence-based activism, that is very much sort of the speak that we learn in medical school. And I'm wondering, is that part, or if you could just speak to really what drove PNHP to be both single provider and single issue? Was it that goal of physicians speaking to physicians, or of generating that data, but just about sort of that decision back in the 80s?
Well, it was developed by physicians who, by definition, provided healthcare. And so that's where their expertise was. And so it was a logical next step to, this is what we do, this is what we strive to do well. We just want to do it for more people. And they knew the other social injustices that were happening in the country at the time that were undermining the ability to change what was wrong. And so that's why it is still single focused. And to this day, it is still single focused, even though we collaborate with other groups that may not be just about healthcare, but for all the other rights that people are disenfranchised from in this country. Because if we don't focus on that, you'll never get the endpoint that you want, because it'll get diluted out by working with all these other issues. You end up having to compromise. And not that any legislation ends up being a compromise, but that's the way that we have to get to our goal. I don't know if that answers your question. Or
I'd like to add a couple of things to that really wonderful wonderful piece that we just heard. And I want to talk about what existed in terms of left-wing activism particularly in the medical profession in the period prior to the initiation of PNHP. And I just want to call out one organization, the Medical Committee for Human Rights, which many of you I think know about. That was an outlet for a lot of politically motivated doctors during particularly the civil rights and anti-war movement of the 1960s. And what's interesting and how it sort of links to what Peter just asked about is that, and by the way, that was a little bit before my time. I mean, I was just, kind of coming of age and didn't enter medical school until 1971. So these were physicians who were a little bit older than me, but these are some of the people who started PNHP. And one of the things about MCHR that I think you should know is that that was an organization in which there was a very distinct physician identity that was carved out and preserved. So it isn't surprising in a way that doctors thinking about organizing around progressive issues would see that as a precedent for what PNHP became. The role involved a lot of the service at mass demonstrations, for example, as well as some policy work. But I think it was a lot more tilted towards these sort of public demonstrations that were a lot more prevalent in those days. And I just want to say one other thing, just to add to what Dr. Rogers said, and that is about unions in the 1950s and unionization. Actually, I just read something fairly depressing this morning about the future of the labor movement and organizing. We're waiting to see what happens with Amazon in Alabama, and I'm not religious, but I'm willing to pray that they actually win their vote. But in the 1950s, at the very peak of the labor movement, about 60% of the private workforce belonged to unions. And that was really a very, very heavily white population. That's something that just to reflect back on what Dr. Rogers was saying about who was excluded from access to good healthcare benefits at the time, and still true. And unfortunately today, 6% is where we're at in terms of unionization of the private workforce. So think about just what a tremendous decline that is in this sort of power of working people to obtain benefits such as even private healthcare insurance. So I'll leave it at that.
Yeah, I think this gets to some really, really interesting questions about how health has been situated in these larger politics. I think Dr. Rogers, you described that there's an element of like being an activist, you don't have to compromise, you like really push a vision. And then on the other hand, like when you're working through politics and getting some of these bills passed, then you really do need to work with politicians whose life is baked around compromise. And I guess one question that is emerging for me is like, who are, like, I'm really curious in sort of the founders of PNHP and their understanding of health. First of all, like, did they consider their understanding of health justice to be rather confrontational, or was it a reflection of where medicine was at the time? And then also, how did they fold in like trying to center other narratives of health justice as they overlapped with issues of racism, sexism, some of these broader issues in thinking about the strategic decision to focus on just healthcare economics through single payer, if that makes sense.
Yeah, that's a big question, but
Sure.
I'll make a stab at it. I think that what they saw, and the founders of PNHP both worked at safety net hospitals. So they saw, just like I did at Cook County, I saw firsthand the inequities. I saw firsthand what happens when people come in and present too late for you to really be able to fix the problem. We saw firsthand, why people can't adhere to a medical plan because they are homeless or they don't, or they are hungry. A lot of things. So they saw those inequities, and one of the ways to fix that was to address it. And they also saw it as a national problem. It wasn't just at their hospital or just in their city. It was a national problem. And so this was the way that they felt that they could address that problem, because it didn't fix the problem if you just did it in one place. It had to be national. And so the whole idea of doing something nationally to fix this is what I think prompted that the energy and the force. And one of the things I do want to add on to what Dr. Gann had mentioned about the medical committee for human rights, who many of them became active in this process too. One of the things too that also evolved at this time in the 70s and 80s was the development of the FQHCs, throughout the country. And that was developed by two groups, the Medical Committee on Human Rights and the Black Panther Party. And so it's these grassroots organizations that created this. You have to work with politicians, because if it's going to be government funded, the money's going to come from them. So you have to go to the people who have the money. But there has to be, even if your endpoints may be a little bit different in terms of, a social activist doesn't want to see a different endpoint. A politician may, because they are willing to compromise more, but it's still, still have to keep your eye on the prize. I don't know of a better expression to, to say that. But that's what prompted this, this need for it to be national. And there were already people who saw that this was a problem. And there were people ready to join in. And although it's been mostly physicians, because health is so interrelated with all the other issues that the poor and disenfranchised have to deal with in life, it's easy to get the group together and support each other in those causes.
I want to jump in with just one more thing about the 1970s, which was kind of like a really, in retrospect, that was like my worst decade, because I think the left really blew it during the 70s. But in listening to Dr. Rogers, I was also remembering another outlet for physicians in the 1970s, which was the National Health Service Corps. And you don't hear very much about that anymore. And if you want to look up somebody who was really a heroic figure in that, read about Fitzhugh Mullen, who died recently, but he was an activist. He was a member of the Lincoln Hospital Collective, which in the Bronx, was an amazing group of people, many of whom came out and were among the founders of PNHP. He was actually given the leadership of the National Health Service Corps, which ties in with FQHCs, because the whole concept was to connect newly graduated physicians with underserved communities and support them in providing primary care. So yeah, that's just an important piece of history, I think, that kind of fills in that gap between the civil rights anti-war era and the onset of the Reagan era.
Yeah, I remember the National Health Service Corps, because when I was in school, that provided scholarships for a lot of students, and you had to go back and for a certain number of years, depending upon how much money you had borrowed. But again, when you think about it, is that it sort of undermines the whole purpose of it when you're only getting people there because they're getting some monetary, advantage out of doing it. And, whereas people who are altruistic and aren't necessarily doing it for the money, there's often no way for them to get involved in that.
Yeah, there was a short-lived, I guess it was a sitcom back in, when was it? Maybe the 90s, about a young doctor who gets, who's in the National Health Service Corps, and he gets sent to Alaska. I don't know if you all,
I don't remember that.
but it was really about this, this guy, this urban person, who's really, basically working off his requirement in the NHSC by going to this, really exotic place in Alaska. But I think, like, where you might also be going with that comment is that this idea of service, serving underserved community, actually just sort of putting your body out there and providing the service in the absence of any kind of movement per se, was also a thing, right? So, and I think it's a thing that affected, I think, a lot of us who were kind of coming into medicine in the 1970s, certainly affected me. So that's kind of sort of saying, like, let's go where there's need, but in the absence of any kind of national movement that would provide us with kind of, a mass organization that we could use to basically, drive fundamental change.
Yeah, in this country, it's like helping poor people is always an afterthought.
Mm-hmm. Yeah.
I think, oh, sorry, go ahead, Dr. Gann.
I'm just going to say the same with, if you go back a few years earlier, I know that free clinics still exist, but, way back, even before I went to medical school, the free clinics were another outlet. And in retrospect, the kinds of things that we were doing in those free clinics were, I guess, pretty good for getting people kind of exposed to problems, but in terms of their ability to address the larger issues, now in retrospect, it's kind of a quaint idea.
So, speaking of large issues sort of requiring large solutions, and also some of the things Dr. Rogers had mentioned about the sort of vision and focus of an activist when that runs into the wall of the compromise of a politician. I just wanted to address an audience question here. If strategically, if you have thoughts on incremental efforts, such as expanding the ACA versus more expansive programs like Medicare for All. I think we're all discouraged by a lack of political will and a broader vision, but I'm wondering if you think efforts like that are counterproductive and we should, as activists, stay focused on Medicare for All, or just sort of what your thoughts are on that.
Well,
Susan, you want to go?
Sure, I'll go. Incrementalism for a lot of things, not just in healthcare, but for anything that you want to change. The problem with that is sometimes the incremental change can become a new normal, and that you get used to that additional benefit, which really doesn't solve the problem. One of the problems with incremental change with our current healthcare system is that almost all of the ones that have been proposed have still done so by taking taxpayer dollars and putting more money into the private insurance companies. Whether it's by the public option, whether it's by the ACA, it's all still building on a system that is structurally faulted. It's kind of like building a house in the sand. I mean, you can do that and then it starts to fall. So you try to prop up this wall, but then you find the other wall isn't working. So it's not a good base. You'll never get a great house if you build it in sand. So as long as we make changes that expand and further cement the role of private insurance company, companies make them richer and more powerful, where we may be providing more care to a few more people. But I don't know if that's really getting us closer to the goal or farther away, because you've given the more and more money and power to the private health insurance companies, to big pharma, to hospital corporations, to physician groups, all of these, you know, wealthy and empowered corporations that have just hijacked healthcare. About the only change that I can see that would help us get to our goal and not do that would be expanding Medicare coverage so that we include the things that like Medicare Advantage has, that we include we include hearing aids, we include long-term care, we include all of those things. So number one, you take away the market for Medicare Advantage. And then everybody is happy in traditional Medicare. There's no reason to get Medicare Advantage. I know that when I was working at one of the neighborhood clinics for Cook County, I was in the Woodlawn neighborhood in Chicago. And across the street from the clinic, there was a large senior housing building, huge apartment building. A lot of our patients came from there. And I was there for 15 years. Some of my patients I knew really, really well. I would see them all. And then I noticed that they're all carrying these Blue Cross Blue Shield tote bags. And I said, where are they getting? Well, the managed care, they had all been over there to that building and signed them up. And they got a tote bag, but it wasn't helping them. In fact, it was hurting them, because now they were going to get a bill for seeing me, because I, as a Cook County hospital clinic, we weren't part of the network. And they didn't know that when they signed up. So it was really just a travesty. You know, so what I think that if we expand and improve Medicare for everybody who's in it, and people will finally realize that they don't need Medicare Advantage. They don't need a private insurance company to lie to you, to tell you, I can get you all these other things for free. I know my sister, who is going deaf, who just turned 65. I tried to talk to her, but I couldn't convince her. She got Medicare Advantage so she could get hearing aids, because that was the only way she was going to be able to get them. And people do that. People will get Medicare Advantage because they need certain things that traditional Medicare right now does not cover. So that's the incremental change that I would promote, that I would work for, that I think will get us closer to our goal without, you know, putting more money in the pockets of private health insurance companies, without pharma, and by improving it, we wouldn't need the supplemental insurance. People wouldn't need to buy that. They wouldn't have unlimited out-of-pocket expenses. So you take away all the negatives of the Medicare, traditional Medicare, while keeping all the positives. And that's the incremental change that I would do.
Okay.
Yeah,
Thank you. Oh, sorry.
I just want to talk a little bit about, you know, where our current federal administration is at, and sort of how we position ourselves vis-a-vis that. We've just seen in the relief bill that was passed that there's some patch ups for the ACA. And, you know, it's kind of hard to argue, given the current practical situation, that those are bad things. You know, so more people are going to be able to get subsidies, and Medicaid expansion is going to be more attractive for some states to pick up. So those are good things. What I think we really need to focus on, you know, this is again a sort of strategic question, are the public option ideas. And in particular, there's a range of them. You know, some of them are, you know, lightweight. And if you go to the other extreme, though, the Medicare Extra plan, which is the one actually that Biden ended up endorsing recently, is probably the most generous in terms of the amount of government control that it would provide, and probably the most likely to put a dent in the uninsured population. So I think it's very important, those of us who are kind of activists and have a chance to speak, particularly to decision makers, we need to really get up on exactly what is wrong with those kind of plans. And you know, Medicare Advantage is another example of what happens when you have competition. You allow for competition between private for-profit enterprise and the public sector. And what's happening in Medicare right now is that Medicare Advantage is growing very fast. And a lot of people don't understand exactly what the problems are with it. So anyway, just to say that I don't mind, for example, if a politician says, I think I agree with, that single payer and the kind of thing that's represented by the, HR 1976. That's great. I agree with all that, but we can't have it. So we're going to have this other thing. That is not, to me, that is not acceptable. I think if you're willing to say that we should have improved Medicare for all, and you're willing to commit to that belief, then it's incumbent on you to show us what steps you believe we need to take to get there and how long it'll take. So you've got increments in HR 1976. It's a 2-year expansion of eligibility for improved Medicare for all. I don't know what the Senate bill will be because we don't have it yet. It had, the last version of it had a 4-year ramp up with the same thing. So I don't mind that at all. I mean, realizing that it's going to be a heavy lift and we need some time to kind of get used to it. But what I really, really don't like is the politician who says, I really think that's the best thing. For sure, that's the best way. But, we can't have it. So let's have this other thing. That's not enough.
Yeah. So thank you for your perspective on how do we tackle this incrementalism question. I think it's particularly relevant in this Biden era where we don't have complete buy-in from a lot of the Democratic establishment. And that's the kind of discussion that we're going to have continually over the next few years. But I kind of want us to go back a little bit to sort of the more fundamental organizing questions of like who's in this movement, who's kind of centered. And one thing that's kind of emerged, and this is very much a function of like where we speak our positions as physicians and medical students. But I also wanted us to have a little bit of discussion about, I wanted us to reflect on the medical hierarchy a little bit, because for example, nurses are some of the biggest proponents of Medicare for all, and unions like NNU are just massive organizations. They have a lot of grassroots power. And I was hoping that we could reflect on what sort of role could Medicare for all have in transforming this medical hierarchy. Would doctors still be at the forefront of it? Like, are we organizing this movement so it enhances our practice of medicine, or could it also flatten the hierarchy a little bit more? How do we think about this very top-down approach versus trying to bring in a more horizontal sort of organizing framework?
I mean, I can react to that a little bit, I guess. I think, one of the backdrops that we all know is happening is that doctors are being more and more welcomed into the proletariat. Nurses have been there a lot longer, and plus they've had to deal with sexism forever. And because of their different status within the hierarchy, I think it's understandable that they would be organized in the way they are as opposed to physicians. I definitely think that, you know, whether we get single payer or not, we're going to see flattening and compression of this hierarchy. We're already seeing it. What interests me a lot, though, is the way in which, when we think about single payer, sometimes we think about it narrowly as a financing mechanism. And we forget the fact that it actually creates a huge number of opportunities to do other things. And one of the things, I was looking at the new bill just the other day, looking for particularly for things that are kind of outside the financing realm. And one of the things is that it would establish an Office of Health Equity. And it would actually allow that office to publicize to a much greater extent, I hope, data on health inequality, but also on issues like food insecurity or housing insecurity, educational disadvantage. These things that we think of in sort of as, and we know that they're probably more important for overall health of the public than a lot of things that we do in the examining room. The other thing it would do is it would allow regional directors, and these would probably be the regional Medicare offices around the country. They would have funding that they could direct towards altering services within under-resourced areas. So there's funding actually in the bill for that, and that could go to all kinds of things that have nothing to do with sort of physician-delivered care, itself. So I think we need to kind of look at particularly when we look at legislation like HR 1976, we have to look at those pieces and look at what happens to them as the bill kind of goes through its process.
Yeah, one of the things that I see that's a little worrisome is as all healthcare providers are now employees, not all, but a larger and larger percentage of physicians are now employees. Physician assistants are mostly employees. Nurses are employees, and nurses have been employees since the beginning. So it was easier for them to feel a connection with the labor movement because that's where they lived, because they were employees. And so one of the things that I think single payer can help prevent is the use of the replacement of physicians with providers who aren't trained the same way to save money. We can argue about whether the care is the same. There's no question a PA can do a lot of things that I do, maybe not everything. They may not think the same way, but that's the issue that can be dealt with. But when you stratify the workers within the profession and you choose the ones that you have to pay the least, that's dangerous. I couldn't believe that this was on the internet. I was looking up something and I came across this website, and it was about how to take an online course to have your own doula company. So you would create a company and you would employ doulas for women in labor. So, and this is already online. And it went through, I looked at the site, and it tells you the classes and what you're going to do and how long it's going to take you, but they're already out there giving you ways to make money off of this. And for you to create your provider group to provide a certain, now I'm not coming down on doulas because they have a role. They have a role. But I think that when we decide on a workforce based on how much it's going to cost versus how well they will provide care, it becomes dangerous. And then you get into turf wars, which we already are seeing now. So I think that the fact that all healthcare providers are, getting closer and closer to being an employee, if they aren't already, it's going to be dangerous in terms of who's providing the care and why is one person providing the care and another one isn't. And it's a whole new, one of the things I think we should realize, and this is true with structural racism, is that the structure is there, but the mechanism to use that structure changes. It's just like with segregated housing. Before, you could have a sign, no blacks, whites only or whatever. Now what you do is your community just zones so that there's no affordable housing that can be built there because it doesn't comply with the zone. So the mechanism changes, but the structure is there. And so what is happening now is that these companies, all they want is money. The structure there is to make money. So the mechanism to do that will be to change the way the workforce functions within that structure. And that's scary. And we have to be careful that we don't just start fighting as providers with mixed levels, different levels of education, different skill sets and all, that we don't fight among ourselves for pennies. We lose sight of the big picture.
And I would add that these issues about basically turf wars are not going to go away if we get single payer.
Right.
And I think it's very important that we accept that reality that physicians and their training is going to have to adapt because, basically government financed healthcare is going to have cost pressures too. And as it becomes clear that there might be people who can be trained in half the time and do a perfectly good job on a lot of things, it's going to be very attractive to the federal government to do that. So I think what it calls for is kind of a continual reexamination of how doctors are trained and what is their value added. And hopefully we'll be able to respond. The medical profession is going to have to respond. I want to, as long as I just brought up the idea of medical school, I just want to say another thing that I think we really need to be working on, and it isn't, again, it's not part of our focus on single payer per se, but we need to change how many doctors there are and who they are. And I really don't see us having, the kind of healthcare system that we want unless we stop this sort of restricted supply of physicians and change the kind of people who get to go to medical school. One of the appeals, I think, of the whole, during the last election where we're talking about college tuition and making that kind of available to anybody who wants to go to a public university. There's absolutely no reason why we should have single payer and still have people going into debt because they went to medical school. It makes no sense.
And addressing the debt, would also encourage more people to become primary care physicians, which
Absolutely.
is what we need. In other countries that have universal coverage, the majority of their physicians are primary care physicians. Mm-hmm. They're not super subspecialists. Peter and I were talking yesterday about how you have a GI specialist that only works in the right upper quadrant and doesn't even remember what's in the left lower quadrant anymore because that's all they focus on. They're just so super special, but that's how they can, generate the incomes they do. But we have to start back with, I remember I had a patient who was incredibly sad. It still bothers me to think about this. This young woman came in, I wasn't attending. And she presented in renal failure. And she had had a long history with rheumatoid arthritis, and she was being followed by rheumatologists and all that. Never, ever had a pap smear. Never. She didn't realize she should, and her specialists never mentioned it. And so we do need the specialists, because she was in renal failure because her cervical cancer had grown and obstructed her kidneys. We don't see that much anymore because women don't get that far in the disease because we find it earlier with screening. But so we need to, address the lack of primary care physicians. And one of those is, like you said, Dr. Gann, is addressing the debt.
That and we have to make the job more appealing. I know from my own experience in primary care that the satisfaction comes from the interactions you have with patients. And when you're constantly stressed for time and you're worried about a million things that you need to check off on the electronic medical record for billing purposes, you don't have a chance to have that kind of relationship. And that goes back to the question of, like, how many doctors do we need, right? Do I really need to see 40 patients a day? Maybe I could see 25 and I could provide better care, get more satisfaction from those encounters. So that's all part of the same thing. I saw a question, by the way, in the chat. I don't know if this is a little bit off topic, but it intrigues me a lot, and I don't want it to go unresponded to. And it's from Noah Schneider. Noah, I know you're there somewhere. It's a question really about innovation and profit motive. And I wonder if, since we haven't heard from any of you all who are kind of out there, Noah, if you could maybe expand a little bit on why you brought this question up and what you've heard about the issue. I would love to hear it.
Yeah, sure, absolutely. So I am actually not a doctor or training to be a doctor. I work in technology, but I've been working on the Medicare for All with Democratic Socialists. But it is sort of an argument I hear from maybe my center right coworkers and family. And it's just that basically, if we didn't have sort of a private health system, there would be no profit incentive to innovate, to come up with new treatments and those types of things. And their argument is just like, that's why you see so many of the medical breakthroughs happening in the United States and richer countries where they are paid more for the care. So I don't know, that's just sort of the question. It's like, how do you counter that argument? Because, to some extent, I think there is a profit motive to come up with the new solutions and those type of things, but like, that doesn't make it right necessarily. Like, it should be equal access for everyone, and they shouldn't just be charging exorbitant prices just because it's the new thing and they can. So.
Wow. Yeah. So, I have a couple of reactions to that. The first one is that if you kind of look at the factors that really determine the health of the public, you sort of think about, what should we be interested in? We should be interested in having the healthiest population we can possibly have. Most of those things that will really, really change that picture, they have nothing to do with some breakthrough drug that a drug company might, help to bring to the market. They have a lot to do with the other things that we were talking about. Are we doing a good job of providing adequate care for the really serious kinds of chronic conditions that people suffer from? So that's happening within the healthcare delivery arena. And then you've got the whole array of public health interventions, which we know historically are far more powerful in terms of improving the overall health of the population. That aside, I think there's a misunderstanding among a lot of people about exactly what the sort of R&D process is in terms of development of new drugs and devices. First of all, most of the basic research is done with public dollars. We pay through our taxes to support the NIH. The Department of Defense, for some reason, because of the Cold War benefit, is now the second largest funder of cancer research, and they've expanded into Parkinson's and a whole lot of other things. So actually our defense budget is also now going towards publicly funded research and development. Where the drug companies come in, for example, is when it comes to being able to organize the super expensive clinical trials. So products are taken out of the basic science labs and academic centers, and then they're basically put into trials that are largely paid for by pharma in return for the intellectual property and the ability to profit from those drugs. I just want to end by saying one thing. The AstraZeneca Oxford vaccine, some of you have probably been reading about its struggles. And I have to tell you that, it's kind of like my sports team that I'm rooting for. They're losing because that vaccine for COVID is the vaccine that was developed explicitly at essentially minimal or no profit for distribution around the world. And I have to believe that when it comes to like something as critical as a vaccine that will help us end, one of the worst pandemics we've had in 100 years, that we don't need to have somebody, a big pharma CEO say like, hey, if I can't add to my, billion-dollar wealth, it's not worth doing. There's plenty of motivations. I don't worry about that at all. I think the real question is, how do we basically get payback for the public investment in some of these things? That's the question that I'm concerned about. But anyway, go AstraZeneca, because they did a good thing, and hopefully they'll be able to straighten out their problems.
Yeah, one of the things I want to believe is that I'm blanking on the guy who created insulin in the 50s, what his name is, who didn't want a patent. I still want to believe that there's people. If I did that and then everyone would know my name for 100 years later, I'd do it for no money.
Jonas Salk, okay, polio vaccine. That was something that was not.
Yeah. But I have to believe that there's people who are still out there who want to find these breakthroughs for the satisfaction of doing it and finding something in an altruistic way. That they're not doing it for the money, but we have a structure that makes it difficult for people to do that, because once it leaves the NIH, it ends up going to a Fortune 500 company. I mean, if we look at Humira, which, the thing about Humira has 295 patents on the drug. It's the only drug out there. So it can't be a generic with 295 patents. So the nature of, and again, it's the structure, and the nature of it is that this is the way it's made to work. This is what capitalism does.
So I had an experience that I can relate about how drug companies sort of think about when to develop a drug. Back in, this is maybe about 15 years ago, there was a lot of excitement about the potential of COX-2 inhibitor drugs to actually prevent cancer. And, things like celecoxib and so on. And so I ended up, I will admit that I was spent some time on an advisory panel for Merck, because they had a clinical trial they were running. They had actually more than one, to see whether or not their drug, which was Vioxx, rofecoxib, would be able to prevent cancer. And if you think about, as they were thinking about the potential market for that, imagine if there was a safe pill that people could take. This sort of idea of cancer chemo prevention was very appealing, because you're talking about a multi-billion-dollar drug, right? They set up the trials in such a way that they were kind of competing to see which of the trials would reach its endpoint first. And one of the things that was pretty clear about these trials was that there was a risk that there was going to be cardiovascular events that were going to lead to the closure of the trial, right? Because there's a data safety monitoring board that was monitoring these trials. There were about 5 of them. And they were in different things. So one of them was on colon polyp prevention. Patient with colon polyps, which put them at risk for a future polyp, were randomly assigned to get rofecoxib or placebo. And some of us on this panel were raising the question of like, well, you know that these drugs raise blood pressure and the likelihood that there could be cardiovascular events that would lead to a necessity to halt the trial, that could happen. And sure enough, that's what happened. So the colon polyp trial showed that there was an excess of cardiovascular events in the people who took rofecoxib. It was a very tiny increase, but it was statistically significant. It was enough. And they immediately stopped the trial. The drug was taken off the market. But not only that, the entire concept of cancer chemoprevention through inexpensive medication that could be affordable and that could, particularly for people who are known to be at higher risk, would actually have been an amazing thing, was shut down. And NCI no longer was very interested in funding that kind of research. Drug companies were beginning to say like, well, okay, if everything worked out, we could make billions of dollars. But to give a pill to people who don't yet have the disease, there has to be an incredibly high margin of safety. And we don't want to take that risk. We're not interested. So I'm saying this as an example of how sort of the motivation, even to continue research that might have led to something that would have actually saved a lot of lives, was shut down because private drug companies saw that they really didn't want to take that risk, and it's essentially a dead field right now.
Yeah, that's a fascinating story, Dr. Gann. Thanks for sharing that and your perspective on this question. I just wanted to give John, one of our audience members who has his hand up right now, an opportunity to chime in and ask a question if he's got one. And it looks like we lost John for the moment there, so that's that's fine. So I had a question. I wanted to tie it back a little bit to an earlier part of the conversation that we were having about physicians sort of being more welcomed into the proletariat, and some of the differences in perspective of organizing, depending on where you know, your sort of historical experience in that really rigid and traditional medical hierarchy. And I wanted to kind of expand on thoughts or strategies around sectoral organizing rather than just professional organizing. Because I think in PNHP and SNAP, we found success in collaborating with nurses and NNU. And I think, you know, it's we all understand, anybody that's been in this fight for single payer, that the more people in healthcare, not in healthcare, but particularly spread out across healthcare that are clamoring for the same thing, the more powerful we are together. So I'm wondering if you could kind of speak to some of the assets and limitations that physicians in particular, since both of you have that role in healthcare, bring to the movement. And if you think, you know, part of the physician training and traditional role is this sort of apartness. I mean, you know, there's a reason that physicians had to be welcomed back into the proletariat despite selling their labor for so long. You know, they are sort of trained to see themselves as separately and often operate that way. So I'm wondering if you could just talk about sort of strategies for how we build alliances with other health professionals, and start to sort of shift our perspective from, the office at the end of the hall that doesn't really interact with the other folks on our team.
Yeah, Susan, you want to take a go at that?
I'll take a stab. I think focusing on the commonality, which is patient care, is one way to create a union. And if you look at all the people involved in just that activity, it's multiple professions, you know. Interestingly, when you look at, protests like for hospital closures or for a particular issue, it ends up being mostly nurses. And I'm not quite sure why. I don't know if it's because they have so much one-on-one time with patients, and it makes them, the connection is there. They learn more of them as a person, not just their disease. I don't know if that's part of it. And then the other thing too is shift work allows you to, have more time versus you're there until you're finished, which is the way doctors function. It's you start when you need to, you end when you need to, versus however, that may be changing. There's a lot of hospitalist programs where they do shift work, but still there's this sense that if you still need to stay, you stay, and that. But I think if we can focus on what the issue is and what is the common theme, and that is patients are suffering. And so if we can focus on that, we should be able to find some way to join forces.
Yeah, I have a couple of things to react to that question. The first one is that you've probably all heard the phrase, the personal is the political. And I think that one of the most important things to remember is that we have the ability to basically create the kind of interpersonal relationships with our coworkers that we want to create, that we do have power to do that. And a lot of times, you guys already know this, especially if you've been out doing rotations. Doctors react to other healthcare workers in a range of ways. And so I think we have, there's a lot to be done in terms of just kind of demonstrating and walking the walk when it comes to respecting other healthcare workers and behaving accordingly. But the other thing I'd like to say is that, just because you're in PNHP or you're in SNAP doesn't mean that you can't get involved in actions with, say, NNU, and particularly NNU, because they're so good at it. And one of the best experiences I've had over the last couple of years in terms of just being involved in the single payer movement was when NNU basically organized street canvassing a couple of years ago. And that was wonderful. So they provided the materials that we needed to pass out on the street. We had they have great signs. We had a couple of nurses in the group, but there were a lot of other people we recruited. So I wouldn't, certainly, I'm sure most of you feel the same way. You don't have to restrict your involvement in the movement to PNHP and a strict focus on single payer as a policy.
Maybe we should get rid of doctors' lounges.
We are, hey, at UIC we already have, right? So
really good.
Yeah, although still, it's a little hard to break that down. So I think they're probably, you do see nurses in there, but we don't see a lot of the other healthcare workers in there. So, but I think anybody, the whole, interesting you brought that up, because I think the excuse for that has always been in the past, well, hey, there's patients are being discussed, right? So you can't be sitting out in the cafeteria. But the fact is that, I mean, medical assistants also know a lot about what's going on with patients, and they don't go into those rooms.
Right.
So,
I mean, and HIPAA tells you what you can say and not say in the elevator, and so
oh
there's,
yeah, that's right.
we follow the rules wherever we release.
And all healthcare workers share that responsibility, right? It doesn't matter whether you're a doctor or you're, a barely above minimum wage medical assistant. You're not supposed to release confidentiality.
Right. But, I just mentioned that because it just, continues this whole idea that doctors are at the top of the pyramid,
Mhm.
and
Mhm.
we're special,
Mhm. Yeah, I have to say that this reminded me back again. This was sort of I've been coming across the word performative a lot lately, and that just popped into my head. Like again, going back to the 70s, one of the things that we used to do, and I was guilty of this too, was kind of rebelling against the way doctors should look, and finding occasions where we didn't want to wear the white coat, did not want to wear a tie, just didn't want to look the way doctors were supposed to look. I, in particular, remember there was a period when I actually got a patch that said Pete on it, that was from somebody who'd be working in an auto repair garage, and I put that on my white coat. And I'm not particularly proud of that right now, and I don't recommend anyone to do that. But what I want to just point out is that this idea, this feeling that you may have that you don't want to adopt this privilege that you feel, first of all, you don't really deserve, and secondly, that you think actually is pejorative. That's a natural feeling, and I think now looking back on it, I think there are probably some better ways that I could have sort of exercised that feeling, but yeah, goes way back 50 years.
Yeah, thank you for that. I mean, I think, as someone entering into the field, hearing both of the importance of just the personal and how you develop those relationships, and also taking an eye to those little structural things. I was eating lunch today, and a group of folks walked into the physician's dining room, there's a big dining room with a great view at Lutheran General, and then there's a separate room off of it that's only for physicians. And that really does reinforce those boundaries that start pretty early in our training, I think.
Now, I did always wear my white coat because as a Black woman, I needed to identify myself. And I mean, that's just the reality of where I was, and not just to staff, but to patients too.
Yeah, I tell you what, I mean, I started thinking more about what patients wanted and less about what I wanted in terms of appearance. And I wanted to do what the patients wanted. If they wanted me to wear a clown costume, I don't know, maybe I'd draw the line at that. But no, I think, you realize kind of what's more superficial and what's really more important. And certainly, respecting what your patients want is super important.
Okay. Yeah, I definitely resonate a lot with just meeting the patient's needs, and also just considering reflecting on where we've come from, what our place in medicine is, and definitely owning up to it. I guess we can get ready to wrap up, but I kind of just want us to think a little bit about where do we go from here. HR 1976 is out now. I think there's a whole lot of organizing, or it represents that this momentum is continuing. I think it'll continue to grow. I think that we have a lot more work to do within the medical profession, but also beyond it. And I think that this movement is provides a really special opportunity to rethink some of our traditions in healthcare and how to move beyond that. So I will just offer this opportunity for you to provide any last thoughts about where do you think things are going, or kind of uh, what should be centered at this moment.
Maybe, Susan, I'll say a couple things and then let you have the last word, okay? Because I know you got to get ready for your other meeting. We're at a sort of a strange time at the moment because we just had the election. We have a number of things that are going to be colliding with the filibuster. And they're enormously consequential. And if I had to predict what will be the thing that really sort of crashes into the filibuster, it's going to be the voting rights bill. Because I really think that, infrastructure can be done with reconciliation. And, there's some chance of some Republican support for that. But it's shaping up really that the voting rights struggle. And if you look at what's in that bill, there's a lot of really good stuff that fundamentally I think is critical. And, it's not going to matter if we have single payer if we can't fix what's wrong with our democracy. So what that means is that we have to be patient, I think, because I don't think we want to be hectoring the Democratic caucus right now and sort of, calling out people specifically because they're not yet supporters of single payer. Doesn't mean that we can't be doing all kinds of organizing. I'm just saying that on the sort of legislative level and what's happening in DC, I think we're going to have to kind of just kind of monitor what's going on and wait for our moment, which will come. I think we just got to be ready.
That's an excellent point, Peter. And I have thought about this as to looking at what is happening today in this country. What's the priority of single payer or Medicare for all? Even if everybody has access, it means nothing if you can get shot by the police walking to that door. Mm-hmm. So sometimes I ask myself, I said, is this where all my energy should be going? And I don't have the right answer to that. I don't know what the right answer is. And I think that, one of the things is as life goes on, your priorities change because the circumstances around you changes. And I am still, clearly single payer is still a priority for me. But if people are dying for other reasons unrelated to health, now access to health care, where should I stand? So it's the difficult, I think we all have to find where we're comfortable. And I'm still comfortable fighting for single payer because I still think it's crucial. We still need this no matter what happens. But I also acknowledge that there's other things that are just as important to be addressed. And Peter, I think your comment about, how much time should Congress be spending on this issue versus the other things that may be more important to making sure that this country doesn't go back to 1864.
Well,
Um,
I think we had a whiff of fascism not too long ago, frankly, and
mhm.
so we have to, we have to realize how serious that threat was,
Yeah,
and is, frankly, it's not over.
right. And I
So,
think, I hope that people understand from, some of the interviews and comments of the people who were at the January 6th riots, that it's not just people of color who are in danger, you know?
yeah.
Well, on this happy note.
Yes, I mean, let's. Yeah. Anyway, it's. I just want to say is that as those of you who are going to be doctors, already are. I mean, there you have to also realize that you do have credibility in this sphere. You will have credibility, notwithstanding what we said about the hierarchy and your proletarianization. And so, we each have to kind of do our part. And I'm not an expert in criminal justice. I'm all for all the great people who are kind of working in that. There are many issues, but healthcare is our thing, and this is a fantastic issue for us, and we've got a good start in organizing. So I'm definitely going to stay with it. I hope you will too.
Yeah.
Well, maybe we should stop in the interest of
Yeah.
Susan getting to her next meeting. I hope you had time for dinner. I mean, I don't know. I'm smelling
It's
some
okay, I
things.
eat all day anyway.
We got to keep our bodies healthy in the meantime.
Yeah.
Yeah.
Well, I
And
enjoyed this discussion. I'm glad you all put this together.
I feel this. I feel the
Yeah,
same. Thank you.
absolutely. Yeah. Thank you so much for joining us. And it was wide ranging. I think as we were planning this, we had talked about how we could spend a whole semester going through some of these questions, and I still feel like that's true. So, hopefully we can have you on again another time. And I really appreciate everything you do and for joining us tonight.
Thanks for organizing it all and being here.
All
Goodbye,
right.
everybody.
Good night.
Good night.
Bye.
Good night.